All right, guys. All right, so have a look at the pelvis. Just to go back momentarily, just keep in mind the pelvic girdle, which we spoke about before. The two pelvic bones join together through the front, through that pubic symphysis. And that's considered part of the appendicular skeleton, which we spoke about before as well. So just with the bony pelvis, it's going to surround the pelvic cavity, which is a very important area, both anatomically and obviously for childbirth, which we'll talk about momentarily as well. So we've got the two hip bones as part of that, along with the sacrum and coccyx, which we know form part of the vertebral column. So I'll just flick over here just to highlight just a couple of things. So the pubic symphysis is just fibrocartilage. It'll remain that way for the lifespan of the person. It won't change at all. So joining the two hip bones together to form the girdle. Just at the back or posteriorly, we've got the high point. Here's the sacrum here and the coccyx. At birth, the sacrum and coccyx are actually separate bones, and they'll fuse as the skeleton matures. Sacral pometry is just the high point of the sacrum, and it'll actually form a joint or an articulation with the L5 vertebra. So we talk about the lumbosacral joint, and we've also got an articulation down here between the bottom or base of the sacrum back onto the coccyx at the sacrococcygeal joint. As I said, the coccyx is actually separate bones of birth, and they'll fuse after birth. It is possible to sublux or disrupt that joint, particularly if you land on your tailbone, which can happen, particularly if you fall from a height. It is possible to actually dislodge or interfere with the normal anatomy through that joint. Not a good thing to be doing. Most people do it at least once or twice throughout their lifespan. We tend to have a bit of a fall at some stage. I've had a couple of people that have had a bit of trauma through this area. They do get, without changing the anatomical alignment of that joint, they end up with a condition called coccydynia, which is constant pain through the coccyx as a result of trauma. It can be very difficult to treat. Now, I just want to highlight just here, we've got the sacroiliac joints just here on the right and left-hand side, and they're really the interface between the appendicular and central axial skeletons. You should have a definite space, joint space, between the sacrum and the ilium at these particular joints. You can see there's a nice defined space here. And you should be able to see that quite clearly if you do an X-ray through that area as well. If people have got degenerative change going on, it could be arthritic. It could be a condition called ankylosing spondylitis, where you start to get fusion of vertebra, and that can affect the sacroiliac area as well. So I've seen a couple of instances clinically where a person's got ankylosing spondylitis as a condition, and you get an X-ray done of the pelvis and the spine, you put it on the light box to have a good look, and you actually see that there's no definite line here. Okay, that area tends to be pretty much scarred up in many ways, and that'll show up quite clearly on an X-ray. All right, so just through this particular area, we've got just the socket here, which is the acetabulum, which is an important component of the hip joint. The head of the femur has a good anatomical fit with that. We've got sort of openings, obviously, as well, so the pelvic cavity through the bony pelvic brim. And the pelvic brim is made up of a number of different bony components. We've also got openings in bone. We tend to call these foramen as well. So we've got a large opening through the front of the pelvic area, the obturator foramen. This is the bony pelvis, keep in mind. This is normally covered by a thin membrane, and this tends to transmit nerves, blood vessels, lymphatics, things like that. Obviously very important for neurovascular structures. You can just see these little projections here at the back as well. These little projections are called the ischial spines, and they're an extremely important anatomical landmark gynecologically. So we tend to measure the distance between those two ischial spines to make sure that there's sufficient space through the birth canal for the baby, obviously during the birthing process. Flat areas, we tend to refer to flat areas as fossa. Okay, so we've got the iliac fossa in this particular area. Okay, up the front here we've got a very prominent landmark, the anterior superior iliac spine is there. Okay, we use it a lot, particularly for clinical assessment. Below that, or inferior to it, we have the anterior inferior iliac spine, which we don't use at all because it's covered by too much soft tissue structure. Okay. Now, it's a bit of a mouthful, anterior superior iliac spine, so we don't use that. Okay. We tend to use ASIS as the abbreviation, and I would use that if I was drafting a letter to someone and there was an issue through that particular area. We also, for the anterior inferior iliac spine, will use AIIS in capitals as an abbreviation there as well. We have little lumps and bumps of bone everywhere that are important for soft tissue attachment, particularly muscle and ligament. We tend to have a number of flatter areas, flat area here, flat area here, flat area here. We refer to these as ramus or rami, and they're quite important for muscle attachment as well. Righto, so those two pubic bones are going to join in the middle of the pubic symphysis. I'll make a bit of a comment here about the pubic symphysis. It's quite possible for that fibrocartilage to become inflamed because there's a lot of muscles that insert in and around that pubic symphysis. Muscles on the inside, what do they tend to be? Yep, adductors. Muscles on the outside tend to be. Yep, so if you've got tight abductors, short tight abductors, obviously you will have long adductors compensating for that imbalance. So if you've got an imbalance between the hip abductors on the outside, i.e. glute medius and minimus, which we had a look at before, if they're short and tight, then you'll potentially have a lengthening in the opposing muscle group. And if you've got lengthening longer than normal, let me go up one, let me go up another one. Okay. So lengthen adductors, there's greater tension, if you like, the eccentric stress through that area, then that's got implications for this. Okay. And believe me, there's a lot of running athletes. There's a lot of running athletes. There's a lot of AFL footballers. They talk about groin pain. Okay, inflammation of the pubic symphysis, osteitis pubis. Okay, and that's one of the reasons why you'll develop osteitis pubis, particularly if you're a running athlete. You've got an imbalance between your abductors and your adductors that needs to be recorrected. Okay. It's not great to have that imbalance if you're a running athlete, because particularly if you're a sprinter, you just want to move in a sagittal plane down a track in a straight line. Flexion, extension. But if you've got issues with abductors and adductors, well, you'll probably spend a little bit of time and energy recorrecting to drive purely through that sagittal plane as well. So that's a bit of an issue if you're a person who needs to run at speed, particularly in a straight line. Sorry, I just got sidetracked there, as I always do. Righto, so we know those two pubic bones meet in the front there through that pubic symphysis. As I said, if there's muscle imbalance between the abductors and adductors, that's a potential risk for that pubic symphysis. Okay. The pelvic cavity is continuous with the abdominal cavity. By that, I mean there's no anatomical structure that really subdivides those two areas. If you're looking at the thorax and the abdomen, what structure subdivides the thorax and the abdomen? What muscle? Yeah, so you've got the diaphragm that's a clear anatomical marker between those two areas. Okay. Obviously, area above the diaphragm's the thorax, the area below, you're coming back into the abdominal area. Okay, but you haven't got that with the abdomen back into the pelvis, so some people don't like to subdivide them, they just refer to the abdominopelvic cavity rather than splitting them up into two. Okay. Spoke about that pelvic brim. It's a bony ring that we find between the two pelves, or the two pelvic bones. Now that bony pelvic brim and its components is going to surround the pelvic inlet as well. Anything through the pelvic inlet surrounded by the pelvic brim, we consider that to be part of what we call the true pelvis. anything above the pelvic inlet, above the pelvic brim back into the abdominal area, we refer to that as a false pelvis. So we subdivide anything above the pelvic inlet as false, anything below the pelvic inlet back into the pelvic cavity is true. I'll say that again because I really want you to get that. That's really important. Okay. So with the pelvic brim, we know it's a bony, made up of different bony components. It'll surround the pelvic inlet. We know that it's bounded by the sacral promontory posteriorly at the back, the high point of the sacrum. You've also got sort of regions of bone, and I'll highlight these to you. Up the front, we've got a thing called the iliopectineal line, and then more probably laterally and coming to the back, we've got a rounded arcuate line. Pubic crest, okay, is a little ridge of bone that just comes off the upper part of the pubic symphysis anteriorly. Pubic crest, just off the cartilage. Pubic tubercle is a little bit more lateral. They're both very important areas for muscle attachment. So 3 separate bones will fuse to form a single hip bone. Ilium, ischium and pubis, and the 2 hip bones together will form the girdle. Okay, here's the pelvic inlet here. Anything through the inlet, we're coming into true pelvis. Anything above the inlet, through this region here, we're back into false pelvis. And this is considered part of the abdominal area. Inferior to or below the pubic symphysis, we have an area called the subpubic angle or subpubic arch. Once again, this is very important in childbirth and gynecologically, so once again that area will be measured anatomically to make sure there's sufficient space for the baby to come down through the birth canal. I've mentioned we'll measure the distance between the ischial spines as well at the back here. Obturator foramen we've spoken about. Here's the ASIS, very important landmark. Off the ASIS we've got the iliac crest, just here. The iliac crest is easy to palpate and feel. We do use it, particularly when we're doing clinical assessment.
If it's insufficient and there's no modern technology, will the mother have severe bleeding?
Well, that can certainly cause problems, definitely, particularly in the last trimester, and particularly in the last period where the head will be engaged anyway, probably. So that's not a great situation for the baby or the mother. You would suspect that person is probably looking at a caesarean section in that particular instance as well. Yeah. So just on this diagram here, I just want to highlight just what we've been talking about. Thanks for that question. Keep the questions coming, guys. Anything you're not sure about, anything you want to add, throw the hand up. Please, feel free. So I just want to highlight just the false pelvis above the brim here. Okay, just back into the abdominal area, and then anything through the pelvic inlet. Okay, here we'll be coming back into true pelvis. Sacral promontory here. We have got foramen, sacral foramen, openings through the sacrum that will transmit nerve, blood vessel and neurovascular structures. We've got sort of these little wing-shaped areas of bone. that tend to come off to the side of the sacrum as well. And we refer to those as being the ala, A-L-A, of the sacrum. I'll highlight these to you in some other diagrams as well. So just looking at the distance between the ischial spines posteriorly is important for us, okay, through that pelvic inlet. As I said before, we certainly would do a measure underneath the pubic symphysis through that subpubic angle. All right, so we do subdivide the pelvis into false pelvis and true pelvis. False pelvis is going to lie superior or above that pelvic brim. It's going to lie between the iliac fossa, those flattened areas on either side of the iliac bone. It's going to form part of the abdominal cavity. So just to highlight a couple of things here, here's the iliac crest, the anterior superior iliac spine. So I'll get everyone to stand up momentarily. You can do this on yourself. Okay, so if you actually come into the iliac crest just on yourself, you can find that quite easily. Everyone got that? Good one to use. So very easy to find surface landmark. What I'll get you to do is just come off the iliac crest. Just want you to find the anterior superior iliac spines on yourself. Got to find them on me. Everyone found those? No problems there. AIIS, no good, we can't get to them directly. So there's no point in trying to use them as a surface landmark. One thing that we can find at the back here, which we use quite a lot, is the posterior superior iliac spines. Okay, they're very easy to find on some people and almost impossible to find on others. Even now, you know, how long have I been in clinic for? Too long. 30 odd years. Some people's PSISs are, blimey, call it an engineer to find these PSISs. They can be very difficult. The easy way to find them is to actually still use the iliac crest. Always start on the iliac crest and then run off the iliac crest, medial, inwards and downwards, posteriorly, and you'll feel these two little depressions and you'll eventually get there. If the person's able to flex or bend forward a little bit without pain or discomfort, that's pretty good because it tends to open up a little depression or dimple through the skin, so you can get into those PSISs pretty easily. I'm pretty easy, I must admit, to find PSISs on. If we're looking at how well aligned is this person through the pelvis, we'll use both the ASIS and the PSISs from a side view to get an idea of how well aligned they are. There's a bit of anatomical variation, males and females, okay, within a normal range. However, if you're sort of palpating the ASIS and the PSIS and the person's sort of like that, they do have a severe anterior pelvic tilt. What would cause a severe pelvic anterior tilt? Good. Yep. So you'd be looking at tight hip flexors there. Rectus femoris could be a potential culprit. If you've got tight hip flexors and a severe anterior pelvic tilt, what will be long and weak at the back? Good. So you're going to have lengthening and weakening and tautness through the hamstrings. Yeah. On the other hand, if you're kind of palpating the ASIS and the PSIS and it's that way, What have you got tight? Yeah, severe posterior tilt, really tight hamstrings, long, weak. Hip flexors, just to allowing for that. And you'll often see it in people's overall posture as well. You can pick it up. Some people are very swayed back. If they've got long, weak hip flexors, the legs come through the door, half an hour the body comes through the door. We normally have a curve in the low back. You know, they're really tight through the extensors, particularly the hamstring. You're looking for that normal curve in the low back. Not finding a normal curve in the low back, that could be a sign that they're very tight through the hamstrings and that pelvis is tilting quite a lot. Very important for people that have had issues with those muscle groups as well. Hopefully you can correct it. Bit of a trick question here. I'll fire this one at you, depending on what we spoke about this morning. Obviously you want to work on the length of the opposing muscle groups, but you'd also have to work on improving the endurance and recruitment through what other muscle group we spoke about today. Yeah, those sort of abdominal, deep abdominal core stabilisers. There's probably a weakness there contributing to this as well. So that's sort of part of the overall picture for that person. So true pelvis is going to lie inferior, below the pelvic brim and pelvic inlet. It'll be limited inferiorly at the lower border by the pelvic outlet, and that pelvic outlet tends to be closed by sort of soft tissue structures, particularly the pelvic diaphragm, which is composed mainly of skeletal muscle. So once again, particularly postpartum or post-birth, people talk about the importance of doing pelvic floor exercises to strengthen that particular area. We have got boundaries here. We love to sort of give things, boundaries in anatomy. Everything's got an artificial or a true boundary. So inferior boundary, if we actually draw an imaginary line from the tip of the coccyx to the inferior lower border of the pubic symphysis, that's considered the anatomical inferior boundary of the true pelvis. Okay. Cavity of that true pelvis is going to help form the pelvic cavity. Okay. It's going to contain pelvic viscera or pelvic organs, including the urinary bladder. Bit of a difference often between female and male pelvises or pelves. Okay, most females, or the most common type of female pelvis, will be the gynecoid pelvis, which has obviously got, it's got advantages in terms of childbirth. So it tends to be the most spacious from an obstetrics point of view. Wide sort of pelvic inlet, wide subpubic arch below the pubic symphysis, and widely spaced ischial spines. So it's really well designed for a childbirth perspective. So once again, there tends to be differences between male and female in terms of the makeup of the pelvis, and that's all probably goes back basically to obviously childbirth. If you're looking at those two pelvises, which one of these two would probably be a female pelvis? Yep, so correct, so wider pubic arch there, wider distance between the wider pelvic brim or inlet, obviously, and also wider distance between the ischial spines. which if we actually were unlucky enough to work in an area where we are discovering human remains, becomes, if you've found a body, it could even be a body of a younger child or even a baby. Yeah, that still gives us clues, even before we've worked out the DNA side of it, gives us clues to, okay, are we dealing with a male or female potentially as well, from that point of view.
Sorry, there's a question over here.
Sorry?
Just start with the question. I was just going to ask, does the male pelvis give them any benefits, like how ours advantage towards birthing? Does the male one actually have any differences that make them advantage, like maybe muscle attachment or something like that?
That's a very good question. Let me have a think. Probably not. That's a good question. No, not really. I think if you go all the way back, obviously, you know, in terms of power output and things like that, we're basically a hunter-gatherer anyway. I'm going to go off on a bit of a tangent here. We are a hunter-gatherer, so probably from the point of view of going out and actively hunting food, there's a bit of an advantage in terms of power production with that type of pelvis, male compared to female, which would have been probably an important thing back in sort of primitive, so-called primitive times in terms of hunting your own food. It is interesting that they've done studies on Afro-American athletes compared to white European athletes, and they've found the elite sort of jumpers, sprinters, particularly with Afro-Americans, tend to have a longer tibia length compared to Europeans, and that certainly gives them a bit of a mechanical advantage in those type of events. They've got to generate a lot of speed and power quite quickly. Thanks for the question. Now, one thing I just want to highlight on this diagram is this roughened area here. The ischial tuberosity. You tend to sit on your ischial tuberosity. Okay. What muscle group attaches off the ischial tuberosity? We're thinking at the back here. A bit further down. That's the one. So this is quite important for hamstring attachment. All three parts, actually. The ischial tuberosity at the back here. Now, I've had a couple of people along the way. I had one lady fall down a set of stairs. Really nasty accident. Take the hamstring straight off. So it's one of the only times I've ever seen it, she actually sheared bone, actually. So the hamstring, musculotendinous attachment hamstring, I actually did it, was intact, but she actually did an avulsion fracture off the ischial tube. Took the whole lot off. Yeah, off the bone. I've had a guy come out on a set of water skis. Really high pressure when you come out of the water. Boof, do the same thing. So obviously people do it playing sport, particularly if they're bending down. You know, that happens quite a bit. They kind of lose balance momentarily. They can do it that way. Okay. We'll talk about the knee in a lot of detail. Unfortunately, even if you momentarily misstep and lose balance with no external force, that can do your ACL as well quite easily. So, it is possible to do some severe damage in and around that ischial tuberosity if you have a severe hamstring injury. And people bleed out quite badly with a high-grade tear. So I remember that lady, black and blue, all the way down the leg to each toe. Yeah, So very nasty, long period of rehab. It really was a 12-month injury by the time he went through the full surgery and then the full rehab process. So don't do that, is really what I'm saying. Okay, so key differences between male and female pelvises. Bones are lighter and thinner. Sacrum is less curved and set more horizontally. Pubic rami are the flat areas of bone, longer. Ischial tuberosities at the back here, important for hamstring attachment, are set further apart and turned outward. Now, the other thing I want to mention here is in and around the pelvis and in and around the sacroiliac area, we have a massive number of ligaments. It's ligament city in many ways through this particular area. This is important because when we actually flex or bend forward through the trunk, what actually should happen is there should be a bit of a counter rotation going on between the ilium and the sacrum, and there should be a tightening up of a number of these ligaments, particularly through the joint capsule of the sacroiliac area. If you've got issues with lack of core control though, okay, particularly if you've got issues with chronic lower back pain due to some issues with the sacroiliac region, then this whole mechanism can get thrown into chaos. Okay? It can really generate a lot of problems for people. It's almost like instead of the sacrum tightening back on the ilium, the sacrum hasn't got the muscle or the soft tissue control, so it's almost dropping down through the pelvic inlet, causing a massive amount of shear stress through that area. So if someone's had a sacroiliac area and they're an athlete, we're coming back into more functional retraining, particularly with strength for them, what I tend to do is they're doing squat work, I tend to get them to avoid bilateral position initially, tend to do a split position. Safer for them. Okay. There's less torsional force through the sacroiliac area. There's less risk of them aggravating soft tissue structures through that particular area as well. Keep in mind as well, and this will happen as part of a normal menstrual cycle obviously, but obviously very important, particularly in the last trimester of childbirth, you will have an increase in a release of a hormone, circulating hormone called relaxin, and relaxin will soften up these ligamentous structures. It will also soften up the discs, the invertebral discs, particularly in the lumbar spine. It'll also soften up the cartilage in the pubic symphysis as well. So obviously, once again, there's a greater degree of give in those fibrocartilage soft tissue structures, which is obviously important for childbirth. So just want to highlight, if we actually have a look at this area, this is from Moores really, but we've got, particularly in that joint capsule between the sacrum and the ilium, we have a large number of quite thick, strong ligaments reinforcing that particular joint capsule. You know, the anterior sacroiliac ligament, that type of thing. We've got sort of superior reinforcement really for that particular area as well. So the ilium, back onto the lumbar spine, iliolumbar ligament. And we've also got a ligament, a very important ligament that runs from the sacrum back to the ischial tuberosity, the sacrotuberous ligament. Let me see if I can find that. Yeah, there it is there. So the sacrotuberous ligament off the ischial tuberosity at the back of the pelvis, okay, back onto the sacrum. You can see that the obturator foramen, that opening through the anterior front part of the pelvis, is normally covered by a thin obturator membrane. There's a little space superiorly to allow transmission of blood vessel and nerve. This is the joint capsule of the hip joint. Thick, strong ligaments in that particular joint capsule. Right, I'll get everyone to stand up again just for a moment. You just to find your iliac crests again. I'll get you to come just down the side of the thigh. You should run into a large bump. Everyone got those? Probably looking at it being, no good with centimetres, 6 to 8 inches below the iliac crest. Got them? 2 large prominent bumps, pretty much straight down the side there. What you're palpating there is this large bony prominence that's part of the femur or thigh bone, the greater trochanter. Okay. It's very important for soft tissue attachment. It's easy to get to, so we use it a lot, once again, for clinical assessment. Okay. There's a smaller medial, here it is here, lesser trochanter, which we don't use at all because it's covered by soft tissue structure. All right, so once again, if we're checking pelvic alignment here, if I'm clinically checking pelvic alignment, using the ASIS, the PSIS, I would tend to use, as a double check, the greater trochanter as well. Okay, just to check to see what's going on with the femur. If I need to measure leg length, I can do that as well, using the ASIS, and then bony landmarks and the pubic symphysis and bony landmarks around the ankle. If I think, oh, well, this person's leg length is, it's really marked, it's way, most of us have a bit of a difference in leg length, but if it's really quite marked and quite significant, it could generate some issues sort of through their low back and hip, knee, etc. All right. So joints of the pelvis are between the last lumbar vertebra and the sacrum, that lumbosacral joint. Don't forget, we've also got a secondary cartilaginous joint between the base of the sacrum and that little tailbone, the coccyx. Okay, the sacrococcygeal joint. They're all joints, keep in mind, and they'll have a fibrous capsule around them, and you tend to get ligaments reinforcing the fibrous capsule. What do ligaments do at a joint? Do they increase movement, have no effect, or decrease movement? Decrease? Yep. Decrease, yep. So if you have significant damage to a ligament, you're going to have more or less movement through a joint. More abnormal movement. So that's worth keeping in mind as well. Okay. Sacroiliac joints we've spoken about. Okay. They're very strong joints. They're really designed to bear weight. A large number of ligaments reinforce the joint capsule of both those joints. Good. All right, now I'm just going to do a little experiment here, guys, which may or may not work. Hang on for a second. Don't worry, your lives are not in danger or anything like that. I'm just going to see if something works in this place. Hang on. I'll have to call IT. Yeah, I've shifted. I've gone into 4. I've gone into overdrive. I'll come back to 3. Yeah. I will come back to 3. 2 I'll come back to as well. I just wanted to get into bony pelvis, but I will come back to it. Yeah. Yes. It's a miracle. Good. So now you'll install that. If we do it here. No, I won't do it here. I'll get the guys in to do it. Righto. Sorry guys, just let me try this. Let's get that. All right, just on here, guys, I want to highlight a couple of things that we've spoken about today. These are the wing-shaped areas just off the side of the sacrum that I mentioned briefly before. The ala, ALA, just highlighted here, more on the lateral or outer part of the sacrum. Iliac crest is highlighted, which we're able to palpate as a surface landmark. The ASIS we've palpated as a surface landmark. The flat iliac fossa, which is above the pelvic brim, part of the abdominal area and part of the false pelvis. Here's our obturator foramen through the front. Fibro cartilage from the pubic symphysis has been removed. The AIIS, which we can't palpate directly and don't use as a surface landmark, is still important for muscle and soft tissue attachment, is just here. Just a couple of things just off the pubic symphysis. Now, I've got to get sort of highlight just the pubic crest. Very important for muscle and soft tissue damage. So it's just off the fibro cartilage of the pubic symphysis, just in here. A little bit more lateral. Important for muscle attachment is the pubic tubercle, just here. flat areas of bone we call ramus. So we've got the superior ramus of the pubis here, inferior ramus of the pubis down here, highlighted. Ramus, flat ramus of the ischium is highlighted as well. So still quite important for soft tissue attachment. Right, I'll come back and we'll have a look at these again next time. Guys, we will see you next week. So this is working. Right like that.
I'm not a student, I'm just a care worker for duration. My partner has got lines in his groin. That's an operation.
Yep.
And even when we have some sexual intercourse, he's vulnerable.
Yep.
He's got the steroids.
I reckon, has he had a disc or lower back problem at all? Or?
Yeah, that's what we're thinking. We're thinking because of his back problem.
Yep.
Maybe that's why he's getting those.
I would suspect if he's had a problem with his lower back,
He's had an operation on his back.
he's had a fusion. Did he have a disc injury or did he have a fusion done to repair facet joints in his back? Do you know? Or, well, I'd still be.
There's no care with his back, you know.
Yeah, I'd still be suspecting there's an issue with pain referral from his lumbar spine back down into the groin area. That could be part of the problem. I mean, obviously taking the steroid-based medication is going to give him some relief with the nerve root inflammation and pain, but it's the sort of thing that if he's got an issue with, he still needs to do, from my point of view, if he's got that pain going on here, he probably still needs to go and see a decent spinal physio. He's going to have to do some retraining there. The best thing he could do is go to keloid physiotherapy and get a real-time ultrasound examination. We'll see if we can get him to see Jenny Hines, and she's got the expertise to do a real-time. She'll do a real-time ultrasound examination of his lumbar spine, pelvic area. Yeah, because you probably need to have that sort of specialised assessment done. If you want to know whether he can recruit, I doubt that he can recruit and use those stabiliser muscles effectively. Yeah, Jenny. H-Y-N-E-S. And she's a keloid road physiotherapy. She's in Melbourne as well. It's pretty close to the site I see here. And you need to perhaps look at getting a real-time ultrasound assessment done. Real-time ultrasound assessment. I mean, it'd be worth seeing how well the musculature's working there, because if it's not working well, it's going to be contributing to instability.